our TCEP MSC, Callie, and she is going to introduce our next speaker.
Hey, thanks again so much, Dr. Sontag. That was super informational and interesting, and we really appreciate you coming. My name's Callie. Like Lauren said, I'm TCEP MSC secretary for this year. I'm a third year at Texas Tech in Lubbock. Our next speaker is entirely Texas trained. She went to Texas A&M Health Science Center, Bryan campus, then trained at Texas A&M Scott and White, where she stayed on as faculty and then became the clerkship director. She's currently Associate Program Director of Baylor Scott and White Emergency Medicine Residency in Temple, Texas. I'm very happy to introduce Dr. Victoria Klovenski, who's presenting the top 3 qualities of a student who honors clerkships.
Hi guys, nice to see you all this morning. You guys got up bright and early on a Saturday to get going. I guess I got to sleep in a little bit later, but thanks for the great intro. I just want to say thanks to the TCEP folks for inviting me back to do this topic. This was originally planned for our April meeting that got coronavirus, and so they were nice enough to ask me to go ahead and come on back and see if I could talk to you guys about this. The original talk was scheduled for about 10 minutes. I think I have 30 minutes today, so I'm going to expand a little bit on what I was planning on talking about then, and then hopefully we'll have plenty of times to answer any questions that you guys have. And please feel free to shoot anything that you have this direction as well. So for my talk, like she said, it's about the top 3 qualities to honor a clerkship. I'm going to pull up a share screen here for just 1 second. So when we talk about honoring a clerkship, there's probably several reasons that you do a clerkship if you're interested in emergency medicine. There's a lot of good things that come out of it. The program gets to know you better. You get to know the program better. You get exposed to emergency medicine. There's several things, but if we're honest with ourselves, probably one of the most important things to you guys as medical students is getting that letter of recommendation and doing well on the SLO. For any of you guys that maybe are younger students out there, the SLO is a standardized letter of evaluation, and emergency medicine has done this really neat thing that I think is great. I think all of the program directors and APDs will agree that the standardized letters of evaluations has really changed the game for us. Basically what happens is when you do a clerkship, all of the EM residencies will write you this SLO that goes in with your ARIS application. And the great thing about the SLO is it asks some very specific, very subjective questions to really line everybody up on this spectrum of how you did as a rotating student. So if you've never looked at a SLO, I would definitely recommend that you do so. This I actually just grabbed by Googling SLO, emergency medicine SLO, so it's very much out there. You can find it. There are several questions that they ask on the SLO, but it kind of comes down to 2 main parts. So there's a part where we write a narrative. And so the narrative is basically a paragraph where we described how you did as a student, a little bit about you, kind of give a better idea of you as a student. But then there's these 2 questions that I think are the real kind of meat of the SLO. So you can see the first one here says, compared to other EM residency candidates, this candidate's in the top 10%, top third, middle third, lower third. So this is a very, very subjective thing. What we do here at Scott and White is we will weight several blocks of students, and then we'll kind of put them all together, and we'll quite literally just line you up in a row as far as your grade from the rotation. So your grades, clinical skills, participation in SIMS, the shelf exam that you take, and we'll quite literally line everybody up, put them in this order, and then give them a very subjective ranking on where you fell from the clerkship. Now, this second question here asks us where we estimate the candidate will reside on our rank list. So this one's much more objective. So again, top 10%, top third, all the way to unlikely to be on our rank list. So this one is where we're able to say, this student did really great on the clerkship, but maybe isn't, what we're looking for, or maybe the other way, like this was a middle of the road student on the clerkship as far as the grade went, but we loved them. We're ranking them in the top 10%. So you might imagine we get a lot of these SLOs that come in during application season, so it gets a little bit shorthanded. So what we actually do is we kind of call these by numbers. So we call a top 10% a 1, top third a 2, and so forth from there. So the best that you can do on a SLO would be a 1-1, for example. A 3-3 SLO is kind of the middle of the road. This person's going to do great. They're going to be a good resident. We have no concerns about them whatsoever. Anybody with a 1 or a 2 in their SLO really stands out. We really like to see that. And then anybody with a 4 or 5 is not necessarily blacklisted, but is a little bit of a red flag. So you really want to kind of keep that in mind as you're going through your clerkships. So the reason that I brought this up as we're talking about the ways to honor your clerkship is because really you're striving for a 1. That's what you're trying to get. And so when I originally made this talk for back in April, I did this really corny thing where I decided that the top 3 things were going to be this one, the O, N, and E. So y'all are going to have to bear with me here as we go through this very lamely here. So for O, so O is for own your patient. So what I mean by this is we want you to take full responsibility for any of the patients that you're seeing in the department. So from the very beginning, you're going to go evaluate that patient, take the history and the physical, going to develop a plan, and then come back and talk to your staff or your resident about that plan. The biggest difference between a 4th year medical student and an intern is developing the differential and developing the plan. We all know you can take a history and physical at this point. We know you've got that down. So what we really want to see is that you can develop that differential and you can develop that plan to go along with it. We don't care that you're right, to be honest. We're not looking for you to be right. We're just looking that you are working on developing that differential and that plan. So come back, tell us the differential and the plan, but keep with the patient from there. So follow up with them on their results, look for their lab results, look for their imaging, go back and reevaluate them. Did you, give them a breathing treatment? Go back and listen to them again. How are their lungs sounding? Did you give them pain medicine? How are they feeling? Are they feeling any better? Kind of follow up on that patient as you go along. Once you come back and tell us about the patient, don't give up on them. Kind of continue from there. As soon as you know about a disposition, maybe you need a consult surgery, maybe they can go home, maybe they need to be admitted, kind of work on developing those disposition plans and let your staff or your resident know what you're planning on doing with that patient. And then follow it all the way through to the end. Ask your resident, can I call the consultant? Can I talk to the surgeon? Let them know this patient has an appy. Or if they're going home, go give the discharge talk. Tell the patient that they're okay to go home. This is what we found on the lab and the workup. This is what we think is going on. This is what I'd like for you to do at home to take care of your symptoms, and this is what I'd like your follow-up to be. We really want to see that you're owning the patient all the way through. So don't just give up on them after you go to see the patient. Make sure that you're following them through and owning the patient. For N here is never stop. So one thing I think all ER doctors will agree on is you've got to have a really good work ethic to be a good ER doc. It doesn't really matter where you go from here. If you're at a huge facility that's seeing a ton of patients, you're of course going to have a good work ethic. If you're going to a rural place that's a little bit slower, the reality is that you just never know when you're going to get bolused with a lot of patients. And so we want to make sure that you have the work ethic to do well in this field. So there are going to be times undoubtedly on your rotation that the resident you're working with or the staff that you're working with is caught up and running around doing a million things at once and you just can't find them. You don't even know where they are to try to be helpful. So always find something to do. Always find something to make yourself a productive member of that team. So go see the new patient. There's a new patient on the board. You have no idea where your resident is. It doesn't matter. Go find that new patient. Just go see them. That way, when you do find your resident, you can say, hey, I've already seen this one. This one's what's going on. Or use this time to reevaluate the patients that you've already seen. Go back and check on them, see how they're doing. Just constantly find something to kind of make yourself busy, make yourself helpful to the team. You might be lucky enough to be on like a slow night shift where there's just not a new patient to see, or maybe there's not that reevaluation that needs to be done, but there's always something you can find to do. So one thing I'll always encourage our students is, just go grab the ultrasound and just go ultrasound the patients that are down there just for education. Tell the patient, I'm quite literally just doing this to practice. Is that okay with you? And then practice fast exams or look at their lungs or just do something to kind of better your skills along the way. Maybe you go find a nurse and just shadow them and practice starting IVs. That's something that's always going to be helpful. You're not going to get called for an IV as an ER doctor unless it's very, very difficult. And so being able to start IVs is super helpful. So just go do that. Maybe you can go find the RT, and if they're not busy, ask them to talk to you about vents. There's always somebody down there in the emergency department that can kind of do something to further your education. And we just want to see that you're always running, you're always doing something, you're not just kind of sitting there waiting for the next thing to happen. So as far as doing well on a clerkship, never stop. Make sure you can prove to us that you have that work ethic that is good for emergency medicine. All right, the last one here is just enjoy it. So one thing we really want to see is that you have a passion for emergency medicine. There's a reason you wanted to do this field, and we really just want to see that that you do enjoy your time here in the department. There's so many cool things about the field, and I probably don't need to tell you guys that if you're all here listening to this talk. But just enjoy the fact that there's a variety of patients that you can see. That there's a ton of different procedures that are going on. Just the overall environment of the emergency department. All ERs, doesn't matter where you are pretty laid back places. People are joking, people are having fun, just enjoy that. There are just crazy things happening in the department at all times. I can't tell you how many times I've just stopped on a shift, standing in a patient's room and thought, you know, how did I get here? How exactly did this happen? Because this should not be going on right now. You know, and just enjoy that. That's, you know, that's one of the reasons that we went into this field. That's absolutely one of the things that's going to help you with burnout, is just enjoying the reason that you actually went into this field. And we really want to see that from you too. The reality is that if you're having a good time, we like being around you more. That's really all there is to it. And so just enjoy it while you're there. One thing that we definitely do not want to see, this is kind of the exact opposite of what I'm supposed to be talking to you guys about, but what we don't want to see is, you know, complaining. So one of the worst things you can do as a student is to say that a patient doesn't need to be in the ER, or that the patient's malingering, the patient's just looking for drugs, or whatever that is. We never want to hear that come from you. The unfortunate truth is you probably are going to hear that in the emergency departments that you're around. You know, somebody's going to come back in and say, you know, this alcoholic was just here last night, or I've got to do another pelvic exam. We definitely don't want to hear that coming from you guys. So, you know, ignore the people that are saying that. Please don't be the person to say that as that comes through, because that's going to be something that we definitely don't want to hear from a medical student. But just honestly have fun. If you can do these things, you know, if you're owning your patients, you're showing us clinically that you can handle this job. If you're never stopping, you're showing us that you know, you have the skills and the work ethic to do this. And if you're just enjoying it, we just know that you love emergency medicine. It seems like very straightforward things. But honestly, the students we have that come through that do the best on these clerkships, that's all they do. That's all they do. They work hard. They're fun to be around, and they just take care of their patients. We're not looking for the smartest one. We're not looking for the one who has, you know, all the medical knowledge already figured out. We can teach you anything. We can absolutely teach you anything. We're looking for these basics that kind of come through from the beginning to make sure that you have are going to be successful in emergency medicine. Alrighty, guys, so that is all I have for you here. I'm going to leave my email address up here for just a second before I switch back to video alone. I'm more than happy at any time if you guys have questions to field those via email. Hopefully we'll have plenty of time here to field some questions too. I've recognized some names on here as some fourth-year students. I'm sorry we didn't get this to you guys sooner. Maybe this would have been more helpful for your clerkships, but there's several names I don't recognize, so hopefully there's some younger guys out here too that might be able to use this as they go forward. Okay, guys, I'm going to stop sharing my screen here and just flip it back. And you guys, sorry, Dr. Berger, gave away all the secrets there. Do you guys have any questions? Anything about the clerkship? Anything about application season? This is going to be a crazy application season for any of the fourth years that are coming through. So I'll do my best to, you know, predict the future and say what that's exactly going to look like. Any questions about emergency medicine in general? I'm all y'all's. Y'all shoot forward anything that you might have. Feel free to chat it in or just talk into the screen. Oh, and thanks for posting the slow over there. That's great. I appreciate it. I'm hoping y'all are typing away. That's the deal.
Hey, Dr. Klovenski, thanks for speaking. Would you recommend any specific study resources, or are there things that you've consistently heard from your students who do well that they said, you know, in their off time they use this to study?
Yeah, that's an excellent question. There are so many emergency medicine resources out there. It can get a little confusing. And the other interesting thing is most of you guys are going to be doing like a four-week clerkship, and you can't possibly learn everything about emergency medicine in 4 weeks. So you really have to pare it down. So there's a few things out there that I usually will recommend. I will say that everybody kind of finds something a little bit different that works well for them. So if you're a question bank person, if you already have UWorld from your other rotations, UWorld is actually decent. If you'll do like the medicine questions, the surgery questions, you can actually get pretty far with that if you already just have that one as your basics. There's an EM specific question bank called Roche Review that I, by the way, have no affiliation with whatsoever. But Roche Review is really great, used very heavily among ER residents, and you'll see them using that all the time when you're on these clerkships. That one, unfortunately, you do have to pay for, so it's not free, but it's very EM specific. I will give you a heads up about Roche Review. Our residents use that for studying for their in-training exams, and it is very much pegged to be like an in-training exam type review. It's very, very specific, much more specific than like an MBME would be. Most places are going to have you guys take an MBME. Some places will have you take their own like privately written exam. but it's more specific than NBME. So the reason I tell you that is don't just do the questions. Rosh is great because it has a few paragraphs after every question that goes through some of the basics surrounding that particular topic. That's actually where you guys are going to get the best information from for the NBME, because it's just a little bit on a little bit different level. But that, I think, is the best EM specific question bank out there. The other things that you guys have used for your other rotations actually hold pretty well true for emergency medicine too. Some people have used like case files, some people have used pre-test. Those for the emergency medicine shelf exam is actually pretty good. So if you're looking more for like a book type source to go to, I would go for that. There are really great emergency medicine textbooks out there. Do not use those. It's way too much. There's no way you're going to be able to get through all of that. So definitely find some sort of review source to use to go through that. My students in the past who have done the best probably have done a combination of some sort of question bank and one of those review books. So they've done some Rosh. They probably haven't done all Rosh because there's a lot of questions out there, but they've done some Rosh to get an idea of the question bank style, and then done, you know, a little bit of pre-test or a little bit of case files or something like that to go along the way. So that's a really great question. The other thing is just ask the people a year ahead of you what they use. Probably the best part of that is they're going to give you whatever they used to use. But those are kind of the things that that I would suggest using for your shelf exams and your rotation too. All right. Oh, good. Yeah. So somebody chatted in here that there's a student version of Rosh Review that's more tailored to the NBME. So that's excellent. That's really good. All right. Yeah, IMRA develops all kinds of these small little books. When I was a resident, I had all of all of them. They had ventilator ones, they had sedation meds, antibiotic guides. I think every one of my residents has that antibiotic guide out the entire shift. So absolutely take a look out for those and see what you can find there. Anybody else have any questions?
I have one. So, sorry, is somebody else? Sorry. No, I'm just echoing. I'm gonna
So my question is, later today we're talking a little bit about getting into residency and having talks about that, but what kind of things will help students get into like fourth year away rotations whenever all of that's back to normal? Like, are there any specific rotations that are more important, or what kind of things can we do to stand out for clerkship applications?
Yeah, that's a really great question. And boy, I'm hoping just like you, this is all back to normal next year. I think every residency is going to tell you we love having the away students coming in. It's one of our favorite things. And definitely us here, we have missed this so much this year, not having everybody around. So I'm hopeful that that's exactly the case too, that gets back to normal. So I think probably when you guys are choosing where you want to do your away rotation, it's hard to ignore the fact that a lot of students are going to match at a place that they've done a rotation. So the reason that I say that is that if there are particular places that you are very, very interested in for whatever reason, you maybe need to get in that particular part of the country, you know, because your family's there, or, you know, that's just the place that you've always been interested in, you know, it would be very, very important to try to get a rotation at that place, if at all possible, because there's no doubt that you're more likely to match there. Everybody wants to choose the known student. You know, the known, we already know what we're getting. There's no questions whatsoever. There may be another student that looks better than you on paper, but we just aren't quite sure that maybe there's that one thing about that student that we just don't know. And so there's no doubt that if there's a particular place that you're very, very interested in going to, you've got to try to need to really try to get a rotation there. If you're unsure where you want to go, but you know there's a particular region you want to get into, you probably need to do a rotation in that region too. So for example, you guys are all here on TCEP. So anybody who's an out-of-stater, if you guys are interested in coming to Texas, you probably need to try to do a rotation in Texas. As much as I hate to say this, the honest truth is that if in a regular year, if we get an application that comes through from a student that's from out of state that has a Texas letter associated with it, we kind of already assume you're interested in the area and maybe a little bit more interested in us. The same holds true for elsewhere. So if you're really interested in going to California, you got to go do a rotation in California. If you're really interested in going to the Midwest, you need to do a rotation in that area. So geography really comes into play there. As far as, you know, actually securing that rotation, you guys will apply through VSAS. All of the applications come through. So of course it's important to have a good looking application as that comes through. When I was clerkship director, at least, a lot of this was a guessing game. There was a lot of great students coming through, and I was trying to guess who was actually most interested in our program and who would be a good fit for us. And so I would recommend that if there's one particular place you're very interested in, it does not hurt to reach out very politely to that clerkship coordinator, and just let them know, hi, I'm really interested in your program for this specific reason. So the key here is you cannot do this for every rotation. If you do this for every place that you've applied to, you're going to get caught, more or less. Somehow that's going to get figured out. So make sure you're doing this for the places that you're very, very interested in. And when you shoot them this email, be very specific on why it is that you're interested in that place. So, my fiance, works nearby. They aren't going to be able to get out of that job. We're really wanting to get in this area, or there's something particular about their residency that you're interested in, but you've got to be very specific. So just shooting an email and saying, hey, I'm interested in coming to Scott and White. I really want to get back to Texas. That will get you some way, but if you can tell us something a little bit more specific about why this place, it's really going to catch our eye. We want students coming to us that are interested in us. That's really all there is to that. And so if you can, reach out and be very, very specific, limited, don't do this to every place that you're applying to, very limited, very specific, you're going to be more likely to lock down one of those rotations. Don't be annoying about this, so don't be terribly persistent. They will probably give you some sort of response back that they're looking at applications and that sort of thing. Give it some time before you reach out again. Make sure that you're not overdoing it, because overdoing it's going to put you on the other list that they don't want you coming. So be very respectful about it. Give them plenty of time, but I don't think that it hurts at all to reach out to the clerkship coordinator to let them know that you're interested in the rotation. Is that going to answer what you were going for? Okay, good.
Hi, Dr. Klovenski.
Hey.
Thanks for doing this talk today. I had a quick question. So yesterday we had another clerkship director kind of share their thoughts with the different types of SLOs this year, since we'll be only able to do one EM rotation. As a former clerkship director yourself, what are your thoughts on students getting an OSLO versus, let's say, like an ultrasound EM rotation SLO or non-EM residency EM rotation SLO? Is there any specific ones you guys will be looking for this year, or?
So you're one of the lucky ones that gets to do it different this year, huh? So the reality is everybody understands there's going to be one SLO. So we expect every application to have one real SLO coming through. And the unfortunate truth is this all got sprung on everybody at such a terrible time that we really don't expect you to have anything other than that one SLO. The only thing about letters that's going to be a red flag for you, I think, is if you don't have any real SLO. But we just want you to have one. That's all we're expecting. From there, honestly, it's fair game. We're going to look at all of them the same. Some people were lucky enough to have done ultrasound rotations before COVID hit, and so they're going to have a subspecialty SLO. Some people weren't. Some people were planning on doing that in March, and then they got kicked out because of COVID. And so we absolutely understand that. So our expectations are one real SLO, and then letters from any other source of where those are coming from. So I think if you have been lucky enough to do an ultrasound rotation, tox rotation, you have some sort of contact with another emergency medicine physician, I think it's absolutely appropriate to get them to send in another SLO for you, whether that's the subspecialty SLO or even just an OSLO, maybe that you know them from some other clinical source. I think that that's absolutely fair. But we're going to regard a letter from a surgeon or a letter from a family medicine doc in the OSLO format just the same as we would a subspecialty SLO, because we absolutely understand this was not your fault by any means. Everybody got really blindsided by this. We didn't know what to expect. And so as long as you've got that one real SLO, everything else is going to count for the same. Definitely get the OSLO format though, if that wasn't clear yet. Don't get just a regular letter. Get your surgeon or whoever to write you in the OSLO format.
Thanks.
Yeah.
Hi, Dr. Klovenski. So on for rotations for students, especially when they're doing an audition, would you be able to speak a little bit about what really makes for a strong audition as far as presentation skills, or just, keeping it short, as well as, the right amount of autonomy, kind of walking that line of not being underfoot, but not being a danger to anything as well?
Yeah, so you've kind of figured out the key to clerkships is you've got to be close, but not too close, right? That's exactly the deal. So as far as presentations go, you guys have already probably figured out emergency medicine docs have very short attention spans. We can't quite listen to your internal medicine presentation. We're going to lose you very quickly there. So So what I tell the students is we have an area where all of our doctors have their computers and so forth. We call that the doc box. And then you walk out from there to go to a room. And I tell the students, if you can give me a presentation from the time we leave the doc box to the room, that is perfect, because I can listen to you for that period of time without a problem. Now that's probably really short, to be honest with you. So I'd say you're really looking for a presentation that's about a minute. And by a minute, I mean you're getting through the history, the physical, the differential, and the plan as well. So you really want to learn to kind of pare this down. So one of the great things for us about having these short presentations is we get a very good idea first of what, if you know what's important in the patient presentation. So, you know, if this patient's coming in with lower belly pain and you skip a lot of portions of, you know, even if say you skipped how long it's going on and those sort of things, if you tell me about their belly surgery history, I know that you're already thinking about things like, could this possibly still be appendicitis or those sort of deals. So it's really nice for us to have those very short presentations. So when you're kind of working on paring these sort of things down, get used to telling us what's really important for that particular patient. They're coming in with chest pain. They've had a history of heart attacks before with multiple stents. They most recently had a stent placed 2 weeks ago, and they're not taking their Plavix, by the way. So you haven't told me anything about how long the pain's been going on, what it feels like, anything like that, but you've already told me that you're really concerned about this person because they just had a stent and they're not taking their Plavix. So it's kind of important to pare down what's important for that particular patient. For the physical exam portion, just the portions that are important. So on their belly exam, you know, they were really diffusely tender, but most specifically in the right lower quadrant, they weren't guarding. You know, don't tell me the rest of it if it's not important to the exam. So you can really pare that down. We will ask you anything else we want to know. So if you get a kind of very short presentation style and there's something else we want to know, so maybe we do want to know if that pain radiates anywhere, we'll ask you that. We understand that you're trying to get it to this really quickly. And kind of like I said before, we really want to hear that differential and plan. So even if you're keeping the H&P portion pretty short so that you can tell us that differential, that's okay, because that's more important to us to hear what you're thinking about. When you're presenting an ER patient and you're giving us that differential, always start with the worst possible thing that can be going on. Maybe this patient is coming in with chest pain and it sounds 100% like GERD. You are convinced it's GERD. It's okay to tell us that you think it's GERD, but you also need to tell us, you know, I considered, you know, ACS and dissection and pneumothorax and all of these things, but I don't think those are going on because of whatever reason. So make sure that you're always telling us. It may seem really, really silly. You go see the patient that rolled their ankle and you come back and tell us, like, I think they sprained their ankle. We're going to get x-rays to make sure it's not broken. I think they sprained their ankle, but I don't think it's a septic joint because this was post-traumatic or something like that. Like, make sure you continue to tell us those worst first things. You'll notice that our residents don't do that to us. That's because we've heard them do it so many times as interns and so forth that they, you know, they can jump to the chase. But we definitely want to hear that from you guys. So very, very short, to the point, the points that are most important, and then make sure that you always do the worst first differential and then give us our plan. Like I said, I don't care that your plan's right. Just want to hear that you have a plan. That way we can kind of discuss what you need to do from there. As far as being close but not too close, I think the students that do this the best are those that are always involved with something. They're always doing something, so we always know that you're busy. And then come back and tell us when there are, you know, important things. So you saw a new patient, so that's when you come back and you're like, you know, hey, Dr. So-and-so, I just saw a new patient, or you got the important lab result back. You know, A7 CT is back, and they have appendicitis, or whatever that might be. And so be close to the team, but just when like things are not going on right at that minute, don't be hovering, right? You know, go find something else to do, but definitely stay close enough that we know that you're following up on your patients and that sort of deal. It's a really tight line to walk. But that's kind of how I would recommend doing that one. Okay, I think I've got another question here on the chat. Let's see. Okay. Yeah, so the question on the chat is basically they already have a letter of recommendation and it's not in the OSLO format, but the physician's in a setting that's really heavy with COVID, and should they contact them or not? So yeah, this is going to be a tough one. So if the physician's in a place where they're not going to be able to write you another letter, take the letter that you have. The nice thing about ARIS, so most programs are going to want 3 letters of some sort, but you can upload up to 4 letters. So if the physician's really in a situation where they can't, you know, go back in and write you the OSLO instead, that's fine. Just keep the one that you have. It may be worthwhile thinking about maybe putting a 4th letter in there that's in that OSLO format for maybe a different physician as well. I think most people will be okay that you've got the letter in the regular format there. I think. So the unfortunate thing about regular letters of recommendation is most times we don't really look too closely at those. We don't read them all the way through. They end up reading very similar for every student that comes through. You know, you ask this physician to write you a letter because they like you, and so they all talk about how much they like you, and so that's the only reason that we like the OSLO a little bit better, is because it's more subjectives and gives us a little bit different idea. But I'd say if that physician's in a situation where they're not going to be able to write you another letter, keep the letter you have. Maybe just consider looking for a fourth letter that's in a OSLO format. I hate to give you that advice, but I think that's probably what I would do.
I was wondering, with the personal statement, some places have said it's going to stay the same, and some are saying they're putting more importance on it. What would you say about it?
Yeah, so for this year alone, we have a lot less data points than we usually do for the applicants. You know, usually like for example, at Scott and White, we normally rotate through somewhere around 60 students, and this year we have just a little over 20. So there's a lot less students that we know, and that's the same for everybody across the board. And with us getting fewer SLOs in, this is also the same year that we don't have the SVI for the first time, which is great for you guys, by the way. Really happy for you all about that. But there's a lot less data points that we have this year than we've had before. So I think everything is going to be more important than it was before, to be honest with you. Everybody really weighed so heavily on the SLOs from the other facilities that now that we don't have that, I think we're going to be looking a little bit closer at everything. So the personal statements, I think people are going to look at your MSPEs a little closer than maybe they have before too. And so I think all of that's going to come through. Now, having said that, the thing about personal statements that does not change is that most personal statements don't get you an interview, and most personal statements don't keep you from getting an interview either. By far, the majority of personal statements are there and don't really sway one way or the other. There are some personal statements that we read and they're just so eye-catching. It's like, I just got to meet that person. You know, whatever it is about it, I just really need to meet that person. And so there are very, very few that are going to get you an invite. And then there are very, very few that are going to keep you from getting an invite either. If you don't have a mentor in emergency medicine, definitely find somebody to read that personal statement for you before you turn it in, because you don't want to be one of those people that, you know, you thought this was a really catching story and then you find out later actually it turned a lot of people off and that was the reason you didn't get interviewed. So just get somebody to read your personal statement for you that's in emergency medicine if at all possible. Even if it's not emergency medicine, if you have a internal medicine doc or somebody, just get somebody to read it. Make sure that you're not this person. That is not very often that happens, but you just definitely don't want to be that person. So I don't think I would be any more nervous about writing your personal statement this year than you would be any other year. We're going to read them. We're going to look closely at them. I don't think that they're going to change as far as many of them being able to get you an interview or not get you an interview, but we're definitely going to look closer at them this year just because we need more data points and we don't have as much as we've had before. So make sure you've had somebody look at it and make sure that there's not grammatical errors, things like that. Just be professional about the statement. I don't know that you have to be the best writer that's ever walked across the face of the earth. That's definitely not very common for emergency medicine docs. It's not the type of people we are. But just, have something that's clean, have something that's professional. That's more what we're looking for. Things that will catch our eye on a personal statement is if you can give something that tells us more about you as a person, that's great. The personal statement asks for you to say what it is about emergency medicine or why you chose emergency medicine. So you've got to answer that, but a lot of that ends up being very similar across the board. I did my rotations and I loved surgery, but then I loved internal medicine and, actually pediatrics was pretty cool too. And so that ends up coming across a lot in personal statements, which is fine because you've got to say why you chose emergency medicine. And that's the truth for most of it. But if you can throw in some other personal story that lets us know you a little bit better, even if it's just over a piece of paper, that's great because that's really what we want to kind of what we want to see come through. So for example, last year, this was very specific, but we had a student who was a fire jumper. So they when they had the forest fires or what have you, they would go out and jump down and be the firefighter in that area. I mean, that's very hard to replicate on a normal basis, but it sure caught our eye, and we're like, boy, we just need to meet this person and see what they're like. We've had students come through here that had something as simple like the start of their personal statement was, the cows were out. They're like, okay. And then you kind of keep reading and it's just something that kind of catches your eye as it comes through. So you don't have to have had some amazing life experience, just something that catches our eye that tells us more about you as a human is really what we're looking for on a personal statement. Anyone else? All right. Okay, well, thanks, guys. I think there's a lot of great links over off to the side on getting the EM mentor and the OSLO and the SLO and so forth. And like I said, y'all, please write down my email address. I'm happy to answer any questions y'all have that come up over the course of time for the fourth years. Good luck to you guys. We'll all muddle through this together and figure it out somehow. And for you guys that are a little bit younger, I hope that this evens out, maybe gets a little bit more back to normal from here. I'll be back today. I'm coming back for the PD panel and for the speed dating too. So if any of you guys are hanging around for the speed dating, come check us out. I'm going to be there with one of our other APDs and several of our residents. So hopefully we can get to meet y'all a little bit more one-on-one there and talk to you a little bit more. All right. Well, thank y'all for having me. I appreciate it.
Thank you so much, Dr. Klovenski, for coming to talk to us, especially on this Saturday morning. We appreciate you sharing your time with us and explaining things, especially with times being so weird like they are right now. So thank you so much.
Yeah, absolutely.
I think Blake has some words for everybody.
Awesome. Hi, everyone. We are going to take a few-minute break, just refill your coffee, reset, and then we're going to get going with all things simulation with Dan here at 10:40. So feel free to go do what you need to do, and then we'll see you back in a few minutes. Thank you so much, Dr. Klovenski.